Garg,
Recording in
Chairman
progress.
Neurology, Medanta, Medicity, Gurgaon. He's a very senior neurologist with primary focus on stroke. He has pioneered the role of thrombolysis in acute stroke in his region. He has interest in neurorehabilitation, occupational therapy, and stroke prevention. And his passion in stroke has taken him to UMASS MA USA, and he has tied up with them for stroke prevention, education, treatment, rehabilitation, and latest research. Welcome, sir, to the today's meeting.
Thank you.
We have moderator for today's session, Dr. Atma Ram Bansal. He's a director, Medanta Medicity Gurgaon. He's in charge of comprehensive epilepsy program for Medanta around 15 years. His area of interest is epilepsy and EEG, and he has more than 50 national and international publication, including 2 books on epilepsy. And we are hoping he is an accomplished recipient of numerous scholarships spanning academic career from schooling to college and beyond. Welcome, Dr. Nikita.
Thank you.
And along
within 2 hours. So on examination, she had mild dysarthria and mild facial asymmetry with left UMN facial paresis. No motor deficits. Her power was absolutely normal, and she had very slight ataxia on walking. I'll first show the patient's video. So she had full power. She was walking normally with a slight ataxia, and rest was completely normal. We did her CT stroke protocol. So we could see that there was a dense MCA sign or Sylvian dot sign. And we did her CT perfusion, where, as you can see, there is a increased mean transit time over the right MCA showing a penumbra. That is, the blood volume was increased and there was a perfusion mismatch. So we thrombolized the patient with injection tenecteplase, and the patient improved. Regarding the mechanical thrombectomy, the neurointerventionist and the neurologist, we had a discussion. And given that she had a very low NIHS, only which had improved post tenecteplase, and she had a very high aspect score, as we can see the CT, almost no hypodensity, and she was walking, talking, the mechanical thrombectomy was deferred. And it was advised that patient has close DCS monitoring and to avoid hypertension. However, unfortunately, the attendants, because they saw an improvement post tenecteplase, they took LAMA and they took the patient home. And however, patient came back within 1 day with a deterioration in her GCS. So we did a NCCT brain stat. We activated the stroke code and again did a CT stroke protocol. So what we found in the CT was no significant increase in her hypodensity in the right MCA region. As you can see, this is her presentation when she came to us. So she was very drowsy. Intermittently obeying commands, and there was significant paucity of movements over her left side of the body. And we can see slight facial asymmetry is also there. Upon doing a CT, so as you can see, this was a low aspect, but given the high NIHS, we took the patient for mechanical thrombectomy, and as you can see, there is a M1, M2 junction clot which was there, and they removed this via the mechanical thrombectomy. This is a post-mechanical thrombectomy CT. So as we can see, there was complete resolution and no significant hypodensity was seen post mechanical thrombectomy. She had a complete recovery. Unfortunately, she later succumbed to her primary disease, but post-mechanical, there was a significant improvement seen. So this was an interesting patient where given the low NIHS and high aspect score, we did not initially take the decision of mechanical thrombectomy, and we asked the patient to keep a close monitoring. However, due to the family being reluctant, unfortunately, they took LAMA and they came next day with a significant deterioration, which thankfully improved post-mechanical thrombectomy.
Good. Rishu, can you go to first slide?
Yes, sir.
So this was a patient of carcinoma gallbladder, and she initially she had that infarct, and for which apixaban was started. Why apixaban? Why not antiplatelet or double antiplatelet?
So because this was because she had a hypercoagulable state.
Because she was suffering from carcinoma, and there were no other risk factors.
Yes, sir. No atherosclerotic risk factors.
She was suffering from hypercoagulable state. That is why NOAC was started in the beginning.
Yes.
Okay, good. Second slide. Next. So this time she came. Previous slide. This time she was admitted, and NIHS was 3.
Yes, sir. Very low.
So you even with low NIHS, you thrombolized the patient. Why?
Because, sir, it was disabling to the patient. Because we don't, while thrombolizing, our main aim is if it is disabling, then we need to thrombolize the patient.
So one is even if low NIHS, if a patient is having disabling symptom, you have to thrombolize. Second, minor stroke is no longer a contraindication for thrombolysis. In many situations where patient comes with minor signs or low NIHS, they may progress to a major stroke within hours, minutes, or in a day. So you don't take any risk, and even if a patient comes with low NIHS, patient should be thrombolized. Good. Next slide. Next. So this is a good penumbra which suggests that patient should be taken for mechanical thrombectomy. Penumbra is used for guidance to do mechanical thrombectomy or not for thrombolysis. So penumbra imaging or CT perfusion imaging is not required for thrombolizing the patient. We decided to thrombolize the patient even with low NIHS because it is an indication for thrombolysis. Patient came within window period. Now this perfusion imaging was done for guiding whether mechanical thrombectomy is required or not. But because patient recovered, mechanical thrombectomy was not done, which is a right decision. In my opinion, it's a right decision. Now patient left against medical advice. Here, this is the catch. Patient should be observed. Any patient with large vessel occlusion, even such patient has recovered with thrombolysis, patient should be observed because in 50% of the cases, we see that patient may deteriorate even after thrombolysis, or reocclusion may happen. So such patients should be observed in the hospital. But luckily, she came again within window period for mechanical thrombectomy. You did mechanical thrombectomy and patient recovered. So very well managed. Any questions? If anyone has any question in mind, please ask. Okay, Nikita, you start your case. Good, Rishu. Good case.
Thank you, sir. Thank you, sir.
Sir, Dr. Bansal has also joined.
ARB, you want to comment?
No, sir.
ठीक है. So you are in Bangalore.
Chennai.
Chennai. Okay. ठीक है. चल निकिता, start your case.
Yes, sir. Sir, are my slides visible?
Yes.
When arteries we were trapped, the silent snare. Just a second. It's not this. My slides are not.
What happened?
So, yes, sir. The slide was not moving. This is the first case. This was a 71-year-old male who came to us with a whole history of ischemic stroke in the left MCA region in Jan 2020 with right-sided hemiparesis, now with residual weakness and residual dysarthria. Patient was already on dual antiplatelet and statins. He was a hypertensive. However, all other stroke workup was negative. Now, the patient had presented with 3 episodes of transient right lower limb weakness, which had recovered within 15 minutes. Outside brain imaging was done, which was suggestive of a left temporoparietal chronic infarct with gliosis, and no fresh findings. These are the CT images and the angio images, which just show a chronic gliotic encephalomyelitic area in the left MCA region with a cutoff seen beyond the left M1, which did not show any new fresh changes. However, when the angio was reconstructed and multiplanar reconstruction with thin slices were taken, it was observed carefully that a flap-like structure what could be seen originating from the posterior wall of the ICA. This is the axial section, though not very clear, can show a slight flap-like structure. Therefore, this was a fibrous shelf-like intimal flap originating and projecting into the arterial lumen. How patient underwent DSA for the same, which showed with clarity the flap in the posterior wall of the ICA. And this is the chronic M1 occlusion, which is not attributing to the fresh transient lower limb weakness. Hence, a stent was deployed in the area, which was basically the carotid web, to push the web to the posterior wall so that there is no chances of any further thromboembolism. The second case in the series was another 51-year-old male, type 2 diabetes as his comorbidities. He presented with sudden onset transient dysarthria, again transient, which recovered within few seconds, which was around 4 days ago. And now he had again presented with left-sided weakness with dysarthria and facial deviation towards the right side. MRI brain done showed right MCA territory infarct. The patient was managed conservatively with antiplatelets, again dual, and discharged after 5 days. After a while, he again had symptomatic worsening of the symptoms. And repeat MRI brain showed increase in the size of the MCA infarct. The first infarct images were done outside. This is the one which he came with worsening. Was showing again an area of diffusion restriction which had increased compared to the 5 days previous. Again, CT angio was done, and taking a look at the reconstructed images with thin slices, which are specifically has to be looked for, we could see a projection into the posterior wall. And the axial section is also showing a valve. Again, DSA was done not for diagnostic, but for therapeutic purpose, and a stent was deployed across the same to push the valve, the carotid web against the posterior wall. A third case this time presented not with stroke but TIAs, 3 episodes with a right upper limb weakness and dysarthria occurring in 1 day. 1 episode lasted for an hour and another 2 were 10 to 15 minutes. The NIHS was low. There was only a pronator drift and mild dysarthria. The MRI diffusion images showed diffusion restriction in the left caudate area as well as subcortical area. And again, the angio done was not very clear about the carotid web. However, a slight projection could be seen into the posterior wall of the ICA. So, in all these cases, what should be the plan is the question. Should be a medical management. It should be in the form of antiplatelets, single or dual, or anticoagulants, or carotid stenting. This particular case, because was having recurrent TIAs, was loaded with dual antiplatelets and shifted to the angio suite and again stented. However, all such cases are not to be stented. Now, a little about this carotid web. Basically, as we can see in the diagram, this is a fibromuscular dysplasia, which is basically in the intimal wall and projects into the lumen. However, all carotid webs like these are not symptomatic, and hence all of them are not to be treated. However, only in some cases there is blood stasis leading to abnormal and altered hemodynamic blood flow, which further leads to stasis of the blood between the intimal reflection as well as the carotid wall. This leads to formation of thrombogenesis. And in between, there will be embolism from this thrombus, and patient will have recurrent TIA or in some cases stroke also. Hence, only when patient is having recurrent TIA or has developed a stroke with high NHS is the carotid web treated. Histologically, as discussed, there it is an intimal hyperplasia. The stroke risk in all carotid webs is not similar. It is associated to their size as well as morphology. For example, length of more than 3 mm are high risk. Acute angle relative to the carotid wall leading to greater thrombogenesis is high risk, and greater than 50% occupancy of the carotid bulb. Because usually carotid webs are not known to cause severe carotid stenosis. This was a review article on carotid web by Yuan Chen, who had discussed the prevalence of webs and their risk of stroke recurrence according to the treatment modality. So overall prevalence was found to be less than 1%, which shows that it is a very rare cause and missed cause of acute ischemic stroke. In patients with no other comorbidities, the statistics showed 13%. Now the recurrence risk was based on the treatment given. If the patient was only on medical therapy like single or dual or anticoagulant, the recurrence rate, which is quite high, was 10%. However, if stenting or endarterectomy was done, the recurrence rate was 0%. In these diagrams, we can show CT angio as well as DSA, which are showing these carotid webs. Now, imaging wise, though there is no well-defined guidelines for this, other different parameters like CT angio, MR angio with or without contrast, ultrasound itself, catheter angiography can be used. However, they say that CT angio is considered as the first line neck vessel imaging modality. You can use MR and ultrasound imaging also as only as adjunctive modalities. And while interpreting CT angio also, we usually miss it on while, visualizing it normally. So therefore, these multiplanar reconstruction should be done, which basically from a high volume of these slices, they only look at the diagnostic and thin cuts. And for typical carotid web lesions, this conventional catheter angiography, which one might think is superior. However, by data, it is not superior to CT angiography, and it is only reserved if you want to do therapeutic stenting or only if there's an uncertainty. So treatments vary. There's no well-defined guidelines by AHA or ASA associations. If only low NIHs and there is thrombogenesis, initially patient can be treated with anticoagulation. In case of carotid web for stroke recurrence prevention, that is secondary prevention, single antiplatelet has also been used. However, some physicians, neurologists also use dual antiplatelets. However, as discussed, the recurrence rate is quite high in this category, almost 20% in 2 years. Stenting and endarterectomy, our safety profile are great, easy navigation across the aorta, minimally invasive compared to endarterectomy. Though even after stenting, patient is put on single antiplatelet just in case, and the recurrence rate is 0%. Same for endarterectomy. Thank you.
Nikita, very good case series and very informative. So the learning point is the first part is uh, medical treatment of choice in recurrent TIAs or ischemic stroke. So in my opinion, patient should be put on double antiplatelet initially, should be continued for 3 months and then switch to single antiplatelet. If patient is having recurrent TIA or stroke on double antiplatelet, then as per COMPASS trial, this patient should be shifted to single antiplatelet along with anticoagulant. COMPASS trial used Revaroxaban 2.5 milligram twice a day along with aspirin. But at times we put such patients on aspirin along with Eliquis, apixaban 5 milligram twice a day. And that this strategy is working very well. Second part, which is very important, is to find out the etiology other than atherosclerotic risk factors. What is the other etiology? Whether this is atrial fibrillation or cardioembolic stroke because of valve disease, or patient is suffering from any hypercoagulable state or vasculitis. So in this case, this etiology is carotid web. And carotid web, in my opinion, is a milder form of carotid dissection. So it is most of the time it is asymptomatic, possibly because of some problem in the vessel wall. But once web is formed and blood is stagnant, stasis of blood happens in this web, it acts like a atrial left atria. So it is like left atrial atria, which where blood is stagnated and cardioembolic stroke happens. Similarly, in carotid web, blood is stagnant, and from there, embolus can dislodge and go to various parts of brain. And in such a situation, my preference always would be to put a stent, like what we do in atrial appendage closure. Left atrial appendage closure is done in recurrent cardioembolic stroke. Similarly, recurrent TIAs or recurrent strokes with carotid web, in my opinion, should be stented. If stenting is not possible, then definitely treatment of choice. If atherosclerosis, then antiplatelet along with anticoagulant. If no atherosclerosis, then simple anticoagulant. Any questions, Atmaram? Any comments? आत्माराम बिजी दिखता है. चलो, any questions from audience?
So currently we don't have any questions.
Okay, fine. So we can conclude.
Yes, sir.
So today's discussion, there are 3-4 learning points. One is treatment of choice in hypercoagulable state when patient is not suffering from atherosclerosis, anticoagulation. Newer oral anticoagulants are now used. We use in most of the situations except valvular atrial fibrillation. We use newer oral anticoagulants. Atherosclerosis, we put patient on double antiplatelet. Recurrent stroke, we put patient on antiplatelet along with anticoagulant. And if patient is having recurrent TIA because of some mechanical problem, then stenting is the treatment of choice, as we did in carotid web situation. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you very much, sir, for this quick recap and very good feedback. Thank you to the two speakers to present such interesting cases, and thank you, Bansal sir, for your moderation. And I guess we can end this meeting now. Thank you very
Okay,
much.
Pratiksha, thank you. Thank you.
Thank you.
Bye. Bye.
Good night.
Good night.
Nice, sir.
Bye.